So I'm going to talk to you a little bit about obstacles to these outcomes of cystectomy. I'm not sure I'm going to give you answers to some of these, but I really just want to give you some food for thought to some of these aspects and obstacles that we face. So bladder cancer, common statistics, these are from the last year, 17,000 deaths. It's really remained relatively stable. Cystectomy remains our gold standard for non-invasive and muscle-invasive disease. I like to think of bladder cancer and its management, which is one of my main clinical focuses, is a bit like a tiger, right? It can be kind of a caged tiger, predictable. We kind of know what it's going to do next, and we can handle it. And these are where intravesical therapies and bladder preservation has a role. But it also can be a very unpredictable, uncaged tiger, doing unpredictable things. We don't know what this tiger is going to do next. And this is the kind of tiger, though, that we have to be much more aggressive about and look to more aggressive treatments, including things like cystectomy. I think we need to look to improve outcomes, as Dr. Gonzago talked about. We are seeing an increased number of patients with invasive disease, an aging population in bladder cancer, which mean an aging population in general, which is going to mean more bladder cancers and cystectomies. We're seeing ad hoc regionalization, referral practices for the complexity of cystectomy, and again, the reimbursement environment. We talked about RVUs yesterday and so forth. Complications, this is a highly morbid and potentially lethal operation. You see 90-day complications, 78%, 3/4 of the patients will have this. When I look back at my talks on cystectomy and complication rates, over the years, the last 20 years, the numbers, my complication rates always go up. I don't think it's because I'm doing a worse job, but the way we capture complications is much more thorough. And I think you really have to look up to 90 days, and we'll talk about that. Half of the complications actually happen 30 to 90 days. Readmission rates, it's really close, over 40%, 42, 43%. And pay attention to this, 10% 90-day mortality. So we got to tell our patients and their families that mom or dad has a 1 in 10 chance that they're not going to be, I mean, we can get them out of the hospital, right? But that's not what they care about. They care about are they going to be alive for Christmas or whatever. So again, significant challenges, but I think these challenges do represent opportunities for us to do better. Dr. Gonzago talked about some of these opportunities: multimodal therapy, chemotherapy, adjuvant, neoadjuvant, newer agents, less toxic agents, pathways, ERAS, and robotics. And I'm really going to focus on this last step, improving the delivery of healthcare. And I think this is something that we don't focus a lot on. It's a very apprenticeship model. We do what we were taught to do. We see what we were taught to see. And we're kind of fixed in that way. And I want to share this. I don't know if anybody has ever seen this before. If you have, don't share the answer. So this is called the candle problem by Gestalt psychologists. So the problem is you're sitting at a table against a wall, and your challenge is to secure the candle to the side wall such that when it's lit, the wax doesn't drip on the table. So think about it just for a minute, and then raise your hand if you have any ideas. Right.
Where those tacks are nails, is that what it is?
Yeah.
So can you put the tray on the wall?
Where the box that they're in?
That's about, yeah, can you put that against the wall?
Yeah, tack the tray to the wall.
And then put the tray inside the wall.
See, you guys are too smart, you know. So the answer is yes. That is the solution. And the issue is, the concept is called functional fixedness. So if I showed you this lower on the right, I think more people would have gotten it easily, right? Because we're used to seeing that box as a container of tacks and not something in and of itself. So functional fixedness is this kind of heuristic thinking of how do we do things is actually seen in younger people. And as we get older and we get into our mid-years and later, we have a lot of functional fixedness, and we can't think past these things. And so it's really, I think, sometimes up to younger urologists, our trainees used to say, to tell us, how do we look at what we have in front of us and do things very differently? Growing up, This was my champion to overcoming functional fixedness, MacGyver. He's not a urologist though, but so that's what I really want to kind of focus on here. Is like, and again, what the things I'm going to show you, I don't really have answers to, but I would like to begin this thought process of how do we get past some of these issues to cystectomy that again may potentially contribute to what Mark said about we're still curing about 50% of the patients and we haven't moved the needle on that. I'm going to talk first about travel distance. So this was a very landmark article by Dr. John Berkmeyer that looked at the benefits of regionalization of healthcare for major surgeries that included radical cystectomy. Higher volume centers may be associated with improved postoperative outcomes. If you really look at that article, it's not that impressive, but there is definitely an effect to that. So we can stand, those of us at academic centers say, okay, send them to the regional centers. Maybe they have to travel, or, in Wyoming and California, North Carolina, where I've been, this is not the tri-state area. Their traveling is 100 miles, 200 miles. So it's significant. But it made me start to think about, is that a problem that they have to travel? Remember, they're going to run into problems postoperatively. We touched on this. So might they get readmitted? So this is a study we did when I was in North Carolina where we looked at SEER Medicare data. Blue is bladder cancer cystectomy. Then there's lung cancer, pancreatectomy, and esophagectomy. Lung is in yellow, and pancreas and esophageal are overlapping there. You see the highest readmission rates are in cystectomy. And you see that rate goes over 40% readmissions, half of that in the first 30 days, half after 30 days. 40% of people will be readmitted. Something worth talking to them about preoperatively so their expectations are managed. The top left is, this is cystectomy here. You can see here the survival by those readmitted. And you see sort of decreasing overall survival in bladder cancer. This is not readmitted, 30-day readmitted, and 30 to 90-day readmitted. So if you're readmitted, you actually have worse survival. Of those who are readmitted, so I think I've said they're going to be readmitted. If they're readmitted, their survival is going to be worse. 30% of those readmitted are readmitted to a different hospital. Likely lower socioeconomic status, medical DRGs. Interestingly, worse survival, only 8% end up being transferred back to the index hospital. So what is the relationship, again, between the distance travel for surgery, because you're going to probably be readmitted closer to home, and how did this affect your 30 and 90-day readmissions? So the hypothesis is that you live longer, you have increased readmissions, and this does negate that kind of Berkmeyer paper of better outcomes. So what we did is we looked in, and this was when I was in North Carolina, the North Carolina registry. At the time, it was called ISIS, and then the name was changed after the terrorist group. I can't remember what it was changed to a more appropriate name. And this allowed us to look at sort of travel distance. We looked kind of zip code of the patient and the provider as the crow flies. This is the numbers. You can see 44% readmitted, half at 30 days, half 30 to 90. A little bit older patients, otherwise no difference who were readmitted or not. I just want to show you this. So this looked at travel distance, less than 30 to greater than 30 miles. Doesn't seem like a lot, but that typically is the definition of excessive travel distance. In the ED world, emergency medicine world, that number is 10 miles. So if you live more than 10 miles, that's excessive travel distance in emergency medicine. Here it's 30, so it's not the 100, it's not the patient who lives in Asheville or who lives in Eureka, California, coming to San Francisco. And this looked at 30-day and 30 to 90-day readmissions, again, all the same findings of higher readmissions in those who lived over 30 miles. So, and then on multivariable analysis, again, that was the only factor of a 30-day readmission was travel distance. Furthermore, if you live farther, your survival is worse. So not only are you going to be readmitted in bladder cancer that we saw, your survival is going to be worse. So I think that this may indeed be a barrier to higher quality care. I think we got to start thinking about how do we benefit them. More follow-ups, phone calls. I think the pandemic has shown us the ability of virtual visits potentially to have a role. Better coordination. Is there a role for health information technology? Why is there a difference between the outside index hospital, between those types of complications, and what can be managed there, what should be transferred? I think there's a lot of potential in health information technology. We've started to partner with Conversa, which is a tech company in the Bay Area, and just to show you of how you can actually track patients from pre-op and their hematuria to their TURBT to neoadjuvant chemotherapy, and they just log in and they tell you, okay, hey, I'm not drinking enough at home. Did you drink X number of glasses of water today or whatever? And then it pings the nurses in our clinic or even with chemotherapy issues and follow them. And I think that may be a one way at least of overcoming some of this. Next is I want to talk a little bit about financial toxicity. Again, another area I'm not sure I have a great answer to this, but important for our patients. Washington Post article, so this is now, it's not just an academic discussion in this room, but is in public press. And I'll just kind of review some of these slides and you can read them. The definition of financial toxicity. So cancer patients are almost 3 times more likely to declare for bankruptcy as those without cancer. We know that with medical issues are a reason for declaring bankruptcy, but cancer adds another threefold factor. Non-elderly patients, so no Medicare, spend 13% spend a fifth of their income on treatment. Medicare patients spend almost $5,000, $1,000 more than those without cancer. These are Medicare patients. Of the survivors, 30% have a burden. Of those with financial toxicity, 86% have health insurance. So we often hear about that. That's not the only answer to addressing this issue. So the question is it's there, right? But is it a health issue? Does it affect quality of life or survival? I think these are impressive on TKI therapy, which can be expensive and very effective for a CML, for example. A $50 copay kept a fifth of the patients from getting continuing their medicines. And for every 13 to 20% increase, there's a 13 to 20% increase or delaying the use of that therapy for every $10 increase in out-of-pocket costs. These aren't large numbers, these aren't big money, but it does affect adherence. Half the patients cut spending on food, clothing, and others, and a significant number do have financial assistance. This is data from SEER from the Northwest. Those who declare for bankruptcy, cancer patients, are more likely to die. So now this is affecting, again, do you survive? This is highest for colorectal and prostate. You can see more likely younger, female, non-white. You can see some of the numbers as far as age and where they live. So I think as far as bladder cancer, we know GU malignancies and specifically bladder cancer has the highest per patient treatment costs of any cancer from birth to death. So what is the effect of financial toxicity in this highest risk population? So we looked at, this is a student that worked with us who's now finishing up her chief resident year at Yale, the prevalence of financial toxicity in this, again, kind of high risk group. We looked at, and it's when I was in North Carolina, kind of a survey, smaller survey, 140 patients surveyed, asking this question, can you pay more than you can afford, and did some quality of life. As you can see here, about a quarter of them did exhibit financial toxicity, did state that they have that. They're younger, they're African American, they're lesser educated, and interestingly, they tend to have non-invasive cancers. Perhaps like the frequency and surveillance and the expense that goes along with that. And just to show you here, it affects a variety of the quality of life measures as well. So this is to summarize kind of what we saw in that. Have to think about the surveillance and what we do. We'll talk about that a little bit tomorrow. And these are some of the next steps, what strategies are in place. I want to finish up with a quick discussion of nutrition because we talked about this a little yesterday. This is the definition of nutritional deficiency. You can read that there. Elderly at an increased risk. Cancer patients are nutritionally deficient, so the elderly cancer patient is at a particularly high risk. So a 70-year-old male presents with bladder cancer, has a bad taste, and maybe a little bit of weight loss before cystectomy, postoperatively, readmitted, wound complications. Dr. Stoffel talked a little bit about this yesterday. The question is, could this have been prevented with some sort of intervention? We've known that nutritional deficiency is a risk factor for complications for surgery. John talked about this yesterday. It's increased wound healing, mortality, survival, financial cost to it. I think urologic surgery, we're in an exceptional position. I don't mean that in a good way, but we operate on older patients. If you take older patients, the NRS 2002, that already hits a score of 3, which is at risk for malnutrition. You add in malignancy, that's another factor. This is an interesting study almost 40 years ago by doctors Terry and Bushin, who were down at UAB, which showed 75%, they were using white blood cell count and albumin, had nutritional deficiency, had complications. Some recent studies here, I'll just touch on a few of these, showing that actually nutritional deficient patients have worse short-term and long-term survival. We talked a little yesterday about sarcopenia. You do have worse outcomes in cancer treatment, in surgery, liver transplant, colorectal surgery. Different ways of measuring sarcopenia. I'll show you a couple of the ways. Cross-sectional imaging is an easy way, and there's some easy software to look at that. So this is how we look at total psoas area. So there are the psoas muscles. And then again, this is sort of the software that looks at it that can quantify total psoas area. This is different. This is lumbar skeletal muscle index, SMI. So you can see here normal, and then the sarcopenic individual. What we found is that by total psoas area, it was a predictor. I think the important question is this modifiable, right? Can you use SARMs or some sort of, we talked about this a bit yesterday, prehabilitation. Lastly, I just want to touch on David Johnson's study, which looked at NISQIP and basically found albumin as a predictor. That's a simple test, right, of complications. In fact, it was one of the only predictors in NISQIP of complications. So how do we assess it? It's not easy. It's not straightforward. Traditional markers are shown here. They don't tend to be very specific, right? They should intake a number of factors. It should be sensitive. It should be specific. Ideally, it should be something where we can correct it and it makes a difference. Some novel factors that are out there. I think indices are really probably the most important. I'll show you a couple of this. This is the MUST tool. Very simple, very easy. A patient can fill this out in the waiting room. 5 steps to it. Again, yet another kind of questionnaire, but something if you want to get a handle on it. This is a much more complex that we have our dietitian, so you can see it can get very complicated. The most important, I think, role in cystectomy is from the patient, the referring MD, to, if it is a referral, to the operating surgeon, because that tends to be the greatest time of delay. When you can just get a patient on boost, I think it's very important to, we talked about this yesterday, to refer them to a nutritionist or a dietitian. I think right away, we have that in our new patient clinic. They see a nutritionist because I think it's so important for them to get the right diet, starting as soon as possible. A lot of them are getting neoadjuvant chemotherapy. That's a 3-month span where we're beating them down further. Or there are things that we could be doing during that point, at least to not tread water. And again, prehab, we've talked a little bit about this. I think physical prehab is important, PTOT, and we talked about this yesterday, smoking cessation. So finishing up here, we need to intervene early. Again, I think the issue is, can we intervene? And is this just a symptom of disease, or is this modifiable? I'd like to think it's modifiable if we can get it early and improve the morbidity or mortality. So we talked about these obstacles. Again, don't have great answers to some of this, but I would just encourage people to start thinking about that and finish with Peter Pronovost is actually the first father of the checklist. He was an ICU doctor for Central Lines at Johns Hopkins. And I think this is true. We need to review healthcare delivery as a science, not just the new molecular marker or the new gene therapy.